Welcome to a review on stroke in the emergency department. The urgency to start evaluation and treatment as soon as possible can make a huge difference on the disability a stroke can cause. Time is brain when dealing with a stroke. This lesson is entailed to guide the healthcare team in the ED with the sequence of events that should take place in order to administer treatment for ischemic strokes. The goal set by the American Heart Association is door to treatment in 60 minutes. The goal for this lesson is to increase the confidence in patient care during a stroke alert. I will review the pathophysiology, the sequence of events prior to patient arrival to the first hour after the patient arrives, describe the implications of increased blood pressure, describe the responsibilities and expectations of the team members, identify appropriate steps for administering TPA, describe the documentation during a stroke alert, and demonstrate how to administer TPA. Let's start with the pathophysiology of an ischemic stroke. An ischemic stroke or cerebral vascular accident is a sudden loss of function from a reduced or complete blockage of blood flow caused by decreased systemic perfusion, low blood pressure, heart failure, or loss of blood, severe stenosis, or occlusion of a blood vessel. Think of the urgency we have when dealing with a heart attack. The same urgency is required for this brain attack. The goal is to administer thrombolytic therapy as soon as possible to decrease stroke symptoms and loss of function for the patient. About 80% of strokes are ischemic. If your patient arrives by ambulance, typically the patch from EMS will include the onset of symptoms and the blood glucose level. The reason being that hypoglycemia can cause focal neurological deficits mimicking a stroke, and severe hypoglycemia alone can cause brain injury. It's important to check the blood glucose and treat a low level immediately. A normal blood glucose is the goal while avoiding marked elevation of serum glucose. Patients with hyperglycemia while having an ischemic stroke have shown to be associated with poor functional outcomes. The emergency physician will determine the need for a stroke alert to be called. If so, the unit secretary will call 333 and request an emergency department stroke alert. At this time, the CAT scan department will be notified so they can arrange to take the patient for imaging as soon as possible. Within the first 10 minutes of the patient's arrival, the physician needs to evaluate for adequate airway, breathing, and circulation. As long as the ABCs are stable, the patient can be triaged as an acuity 2. At this time, the history is obtained, a quick physical assessment is obtained, including National Institute of Health Stroke Scale number. Intravenous access should be obtained, if not done already, by EMS. Consider obtaining a second line when the patient returns from CAT scan. In addition, there will be an order set of lab work, including a complete blood cell count with diff, platelet count, electrolytes, BUN and creatinine, and coagulation. Please be aware that the priority is on obtaining the CAT scan. Do not delay the scan to obtain chest X-ray or EKG or labs, as this can be done once the CAT scan is complete. One of the key questions that must be established is the onset of symptoms. Any unclear or unknown onset will automatically exclude the patient from receiving TPA. Ideally, the thrombolytic therapy needs to be started within 3 hours of onset. In 2009, the time frame was extended to 4.5 hours, as long as the patient meets the criteria of inclusion and exclusion guidelines, although the risk for complications will increase once the symptoms have extended past 3 hours. Within the first 10 minutes, the physician and the nurse must obtain the NIHS score, which is the National Institute of Health Stroke Scale number. This is an excellent tool because it's meant to be quick, simple, and reliable exam that is done at the bedside. Emergency physicians must be able to evaluate stroke patients using this tool in order to give quantifiable information to other members of the stroke team. It is necessary to obtain a baseline score and then continue to repeat the exam at a later time and compare the scores to determine if the patient is getting better or if the stroke symptoms are worsening. This neurological exam includes 15 items focusing on consciousness, language, neglect, visual, motor strength, ataxia, dysarthria, and sensory. The NIH Stroke Scale tool has a maximum score of 42, which will signify a significant stroke and severe outcome. A score of 0 is considered a normal exam. Scores greater than 15 to 20 are more severe. In the exclusion criteria, any NIHS less than 4 and greater than 25 are going to be exclusions or contraindications for TPA. At Griffin, we use the modified NIH stroke scale for nursing staff. So nurses must document the level of consciousness, motor movement, dysarthria, or the difficulty of articulating. This is a speech test, so you are going to ask your patient to repeat certain words, and with the total score, you're going to report any significant change or of 2 or more points. Before the 15-minute mark, the on-call neurologist should be contacted. Since Griffin Hospital is a telestroke center, its hub hospital is Yale New Haven. To communicate with the hub center, use the Y-axis in room 11. It can be utilized 24/7, 365 days a week. Y-axis is used, and the doctor will answer within 5 minutes. The on-call vascular neurologist will perform a real live audiovisual consult with the patient and the ED provider. The ED physician will relay their NIH stroke scale, and they will then obtain their own, and this will help compare and determine what's the best plan for the patient. At this time, you're anticipating the patient going to CAT scans, so nursing responsibilities include placing the patient on a transport cardiac monitor for the CAT scan. In the hyperacute phase of ischemic stroke, CAT scan images are often normal or show subtle changes only. Studies show that MRI can reveal the ischemic lesions in its full extent within minutes. Patients presenting with a sudden focal neurological deficit do not always suffer an ischemic stroke. Approximately 5% of these patients will harbor other diseases or things such as tumors, postictal paresis, multiple sclerosis, hemiplegic migraine, transient ischemic attacks, or even a hypoglycemic or liver disease issue, where MRI is usually far more informative than a CAT scan. Another 10% of these patients will have intracerebral hemorrhage that can easily be detected either by CAT scan or MRI. High sensitivity and the high predicted value of MRI to ischemia helps to avoid unnecessary and potentially dangerous therapeutic interventions and can ensure the effective therapies will not be withheld for those who are suitable for these therapies. The nursing responsibilities at this time is to place the patient on a cardiac monitor, to have the equipment ready for manual blood pressures. We want to work and get things ready in anticipation for TPA. You want to secure a second IV line and get your IV pump ready. Consider placing a Foley catheter for the patient because this patient's going to get TPA. You cannot insert a Foley after the medication has been started. You also want to obtain a weight in kilograms. This is going to help you determine the amount of medication since it is weight-based. An estimated weight is not acceptable, so this is the time where you need to be a little bit creative. Make sure that you have the appropriate scales available to you so that you can get an accurate weight for your patient. One of the relative contraindications is a blood pressure greater than or equal to 180 systolic or 110 diastolic. So one of the goals for a patient who is having high blood pressure is to get that blood pressure under control. We will, for example, use bolus of labetalol or start a drip of labetalol or nitroprusside, and any aggressive treatment, which means multiple boluses or having to increase the drip without much improvement or without the patient reaching systolic under 185 or diastolic under 110, will exclude the patient from getting TPA. So the first line of treatment would be labetalol. We don't carry nicardipine in Griffin Hospital. And then the second line of medication that we would use is nitroprusside. As soon as the decision is made, the nurse can start getting TPA ready. Pradaxa within 72 hours is a relative contraindication. So pay attention to the absolute contraindications versus the relative contraindications, and make sure to always read the labeling insert that comes with TPA because there are changes to the labeling that occurs. And it's important to be up to date with those changes. So within 45 minutes, the expectation is that the MD should receive the results of the imaging scan, and then within 10 minutes of that, the decision should be made as to whether or not thrombolytic therapy is going to be used. So at this time, the MD in the ER and the neurologist and the family or the patient need to make a decision. During this time, the nursing responsibilities include determining the infusion rate, the bolus, and the waist. Make sure that the patient has information about TPA so that they can make the best informed decision. And if you're going to use the dose of TPA that is in our Pyxis in the ER, be sure to call the pharmacy to replace it with another 100 ml vial. So let's review the dosing of TPA. When you mix the water into the powder, the total solution is going to amount to 100 mLs. And it is a 1-to-1, 1 milligram to 1 ml solution, and the maximum dose of TPA is 90 milligrams or 90 mLs. So once you obtain the patient's weight in kilograms, you're going to multiply that by 0.9 milligrams. Okay, so the total dose is 0.9 milligrams per kilogram. Once you have obtained that number, you will multiply that by 0.1 to obtain the bolus dose, or it's 10% of your total dose. Once you have determined the bolus and the total dose, you can determine your waste, okay? So if we have 100 milligrams, you're going to subtract the total dose, and that's how much mLs you're going to take out of the vial. You never want to have more than the total dose that you intend to infuse left in the vial. You can have an infusion going, you can have your IV pumps fail, or the battery dies, or anything that will skew the numbers on your pump, that you may not be able to reflect how much has been infused or how much longer you have to infuse. At least you can know for sure that you're not going to give more than what the patient's total dose is if you had taken the amount of waste out of the vial. The bolus is going to be infused over 1 minute, which can be programmed into our Braun IV smart pumps. And then the continuous infusion rate is going to be the total dose minus the bolus dose, whatever mLs is left, that will be your ml per hour rate. The other thing that you want to have ready is a 50 ml bag of normal saline, so that once the infusion is done after the hour, you can then switch the glass bottle to your normal saline bag and infuse the rest of what's in the tubing. Make sure that you set the pump at the same rate that the TPA was infusing. The standard set by the American Heart Association is to start treatment of TPA within 60 minutes of patient arriving to the emergency department. And the treatment can recanalize blood vessels in up to 50% of patients treated with TPA. The nursing responsibilities once TPA has started is to obtain manual blood pressures every 15 minutes for 2 hours. Be sure to either put a sign above the patient's bed or on the monitor clearly stating no automatic blood pressures for 48 hours from the time that you start TPA. The pressure that the pressure cuff puts on the arm can cause microscopic bleeding, which can cause a lot of bruising and injury to the patient's arm. You want to make sure that there's no unnecessary blood draw, so any blood work that you anticipate needing, make sure you get it before the TPA is started. Watch closely for signs of bleeding. You want to obtain neuro exams every 30 minutes for the first 2 hours post TPA. And you want to make sure that there's a NIH stroke scale documented 2 hours after treatment. If there's any changes of 2 points or more, or any significant change, then this needs to be reported to the physician. If at any point you are giving report or switching shifts, make sure you do an NIH stroke scale or a neuro exam together, and let it be part of your report so that you are consistent as to the questions being asked or the response of your patient. Part of the documenting for a patient getting TPA is to make sure that there is an NIH stroke scale on arrival, and then subsequent scores can be done by the RN. I encourage the RNs to do the NIH stroke scale with the physician so that you're both seeing the same evaluation. The order for TPA and the TPA bolus both need to be put in electronically by the physician so that the nurse can document accordingly the rate, the bolus, how much was wasted. And vital signs need to be obtained every 15 minutes and documented, and neuro signs every 30 minutes and documented. Be sure to always go back to the patient's symptoms and complaints and state how the treatment, how the patient is reacting to the treatment or any interventions that happen along the way. Thank you for taking the time to go over this review. If you have any questions about our stroke policy, any changes that you are concerned about or suggestions, please let me know. If you would like to practice mixing TPA and getting your values, please let me know and we can practice this together. Thank you.